Thanks very much, Andra, and good morning to everybody to this important town hall. Before I make opening remarks, I want to just pause for a moment and acknowledge Dr. Islene Di Carvello from the WHO, who died earlier this week. Islene was formidable. She was knowledgeable, she was smart, she lit up a room when she went into it. She was inquiring and curious. One of the fundamental actions that I saw Islene constantly make was to include everybody. It didn't matter what rank you were, whether you were WHO or industry or NGO or an individual. She just welcomed you and embraced, a conversation with you. I'm missing her very much this week, and I know thousands of people around the world are going to miss her inquiring mind and her work. The work will carry on. She led, a very important body of work, the integrated care of older people policy and program. So as we move forward into this town hall, just acknowledging Islene. Meningitis is deadly and debilitating. It strikes quickly, has serious health, economic and social consequences. And surprisingly, it affects people of all ages around the world and in all countries of the world. Bacterial meningitis can cause epidemics, lead to death within 24 hours, and leave 1 in 5 people with lifelong disability after infection. Many cases of and deaths from meningitis are vaccine preventable, but progress in defeating meningitis lags behind that for other vaccine preventable diseases. Why are we talking about it today? Because we have a responsibility to actually support and align our values and our work around adult vaccination with those of experts and advocates in the field of meningitis, defeating meningitis. As the global impact of COVID pandemic has developed, evaluation and monitoring of this devastating disease, COVID, has been a driving factor for governmental and societal action. Data is pivotal, and in the environment in which we work in the field of ageing, data is always a very sore point. It's pivotal to ensure equitable and accessible health programs and policies now and in the future. This IFA Town Hall explores the Meningitis Research Foundation's Meningitis Progress Tracker. It is a fundamental and critical tool, to drive global awareness. And so not only will we learn today, it is something that we need to take on board when we're talking about other vaccine preventable diseases. We have the great pleasure of 2 speakers this morning, Mr. Rob Dawson, Strategic Communications Director with experience in health and science across industry, public sector and not-for-profits. He's currently Director of Communications, well that's his title, but he has much a broader perspective, advocacy and support at the Meningitis Research Foundation, Chair of the STEM PR Association, and all sorts of other important roles. And Rob will be followed by Linda Glennie. Linda is Director of Research, Evidence and Policy at the Meningitis Research Foundation, a medical research charity and patient group. She is responsible for the development of policy standpoints and evidence-based submissions to WHO and other scientific bodies. I hand the floor to Rob and enjoy this important town hall. Thank you.
Firstly, thank you very, very much for having us. It's great to be able to show you what we're doing in meningitis. And as pointed out, you've probably seen the graphs and charts recently with what's happening with COVID. A lot of those have been used on the news and so on. So we're going to show you today what we're doing in the meningitis space with similar data visualizations and how that's helping us defeat meningitis. So Meningitis Research Foundation has been working towards defeating meningitis for around 30 years now. We started working primarily in the UK and Ireland, campaigning funding research and supporting people affected by meningitis directly as well. And while we've been working in the UK and Ireland, we did have some research projects internationally. So we have always had these sort of international connections, mainly with experts, but now increasingly with individuals, advocates and patient groups around the world too. And we've had a lot of success in the UK. Our work has been instrumental in securing many vaccines for different causes of meningitis, whether that's through funding research directly into kind of vaccine research or campaigning for access to vaccines. And over that kind of 30 years of success, we decided that it was time to try and think how we could use our expertise to help more people around the world. So there were two main approaches when we decided to try and see how we could defeat meningitis globally. We started first to look really at the data and estimates that existed for meningitis to see, where it sat as a global health priority, and to see what needed to be done. And then we also started to work with some of these international connections that we've made over the years to bring them together to try and galvanise support for global action. So Linda's team first looked at the meningitis estimates that were available, and one of the first things they really noticed, first of all, was that the data wasn't very good and needed to be improved. So, it's difficult to prioritise a disease when you don't really know how much there is. But we did have estimates that showed us that it was a big global problem. In compared to other infectious diseases, we also saw that it really lagged behind in terms of progress of defeating it. So the number of cases and deaths weren't falling as quickly as for other vaccine preventable diseases like tetanus and measles. So that was something that immediately grabbed our attention, and we thought, why, what can be done? Why are people not taking as much notice of meningitis as they are of other diseases? And we also noticed that meningitis was missing from a lot of key global health documents. The estimates for meningitis just either weren't there or it wasn't being mentioned at all. So we thought it was difficult for us to tell the story about the need to prioritise meningitis if we didn't have good available data, but also if the data was missing from these documents. So we decided to really try and pull some of that data together to create visualizations that could be compelling and impactful, and started to talk to global health experts, first using quite static images, really using standard graphs and charts. But then as we developed our skills, we started to make those visualizations. And with those very first set data visualizations, we brought people together at several large meetings. We convened people like WHO, CDC, Médecins Sans Frontières, and so on, real kind of global health players, talked them through what we had found, and said, we felt that progress needed to be quicker. We also had the Sustainable Development Goals as a hook. We realised quickly that a lot of the goals set for 2030 around health couldn't be met if we didn't improve things for meningitis. It played such a big role in global health that we knew that meningitis needed to be a part of it to really achieve the Sustainable Development Goals. And so we're bringing together that data with the relevant experts in as I say, a series of meetings. That's really where the idea for a global plan to defeat meningitis was born. And that plan has now, after several meetings, has now been written, drafted, approved by most countries. We're still waiting for a few just to sign on the dotted line. And that global plan, thanks to that first bringing together of data, that global plan is now due to be ratified at the World Health Assembly in November this year. And it's the first ever resolution for meningitis. So we're really excited to see that being prioritised on a global stage. And we have had good feedback from countries to say that they're willing to take that forward. So these visualizations that we made, this better understanding of the data that was there, and by enabling us to tell the story of meningitis, we were able to secure and galvanize action to defeat it. So that data really was a big part of that. And as we've developed the plan further, we've set out goals and targets which we're going to need to monitor progress. So we have a plan, but we want to ensure the plan is taken forward. So there are several goals and targets that have been set in that plan, and we needed a way to monitor them. And those visualizations that we created have become a really useful tool for that. So we're currently still developing it, and Linda's going to take you through it in just a second. But those visualizations, as well as telling the story of meningitis and being able to help us advocate for change, and they're also becoming a really powerful monitoring tool, so that we can say, you know, there are certain steps that are being met, cases are falling, vaccines are increasing, that kind of thing. So it's becoming a useful tool that's been endorsed by the World Health Organization as the tool that will monitor the global plan. So I'm just going to add a couple of links to the chat now, so that you can, you know, go to those pages and find out a bit more. So one of them, the first one I'm going to share with you, is the WHO page, the official page for the roadmap. And then the second one will be the progress tracker. So I'll send those through now, and then I'll hand over to Linda. And Linda's going to talk you through the tracker with a bit of a focus on some of the data we have. We started the tracker with a pilot that just included data for young children. You may, if you think of meningitis, a lot of people obviously think of children because it does affect them. They are at higher risk than other age groups. But as pointed out earlier, it does affect all age groups, and we do now have data for all age groups and all countries. And this version was launched just this week, so you're getting a first view of our latest version. So I'll hand over to Linda, and she's going to take you through the tracker.
That's better. So I'll share my screen with you. Thanks very much for the opportunity to present this to all of you. Can you see that?
Yes, we can, Linda. Yep.
So I'll just go to presentation mode. So this, as Rob was saying, this tool for the first time allows people to access meningitis data and estimates from diverse sources for every age group, every country in the world, all in one place. And it visualizes key information about the estimated 6.3 million annual cases and nearly 500,000 deaths caused by meningitis and neonatal sepsis. It's been adopted now, as Rob alluded to, as the official dashboard for the roadmap. And as such, we've tried to keep it as much as possible aligned to the roadmap pillars of prevention, diagnosis and treatment, surveillance, support and aftercare. But we also need to sort of create a space for us to be able to specifically monitor what the roadmap indicators are telling us. And so we have some additional sort of windows to allow us to do that. It's aimed as a tool obviously for the task force and WHO and partners who are kind of looking at what the roadmap is achieving, but also in general for global health experts, policymakers, public health officials, researchers and academics, advocacy groups, CSOs. It's a teaching tool. So we feel that it has a lot of potential and diverse audiences. The original tracker attracted more than 33,000 users from over 70 countries. So it has had quite a good airing, and we think this version is much better. So this first tab shows you the burden, so estimates of the burden of disease, and it's an interactive thing, so that you can use the buttons on the left to select your measure of the burden of meningitis and neonatal sepsis, deaths, cases, and so on. You can, previously we had only deaths and cases, now we have incidence and mortality. You can select age range, so as you can see, that it's constrained by the way the data are estimated. So although we all know that actually things begin to change probably from 50 onwards, the age bins are already set, so they are what they are. We have the different causes of meningitis, so the leading bacterial causes of meningitis that are well known, as well as neonatal sepsis, and you can select the different ones. You can select regions of the world, so different WHO regions. You can specifically look at what's happening in the meningitis belt, which is this area in sub-Saharan Africa, which has historically had huge epidemics and still has highest burden of disease. You can look at income level and the different sources. The estimates aren't our estimates, obviously, they're modeling efforts, and they come from these sort of different groups that model either syndromic, all meningitis, or specific aspects of meningitis, specific types of meningitis. So it's actually only IHME that shows data in every category. So as you go through, you'll find that data are missing, and it's just because of what the different modeling groups attempt to show. And as you change what you're looking at, so for example, I think if I get rid of the neonatal sepsis category, you'll see that the numbers change here. So the numbers in red change. You can also hover over a country, the country you're from, to get specific information about that country. And it also sort of shows you what filters you have selected and so on. And at the bottom here, you can see we have a little donut graph showing estimated data quality. So as I think both Jane and Rob alluded to, one of the issues is that the estimates that we have to rely on actually aren't based on incredibly great data. So, and the other thing is that as you come to the high burden countries, the data become actually less reliable. So, in the high burden countries, and if I go quickly to the data quality map, you can see that the countries where the burden is highest are the countries where you don't really have very good vital registration data. So in these countries, the estimates are based on autopsy, verbal autopsy, rather than on actual data. And so, there are problems. And this is one of the things that we're hoping that we can help to push forward by doing this. If we draw attention to uncertainty in estimates, it could motivate countries to produce better, to invest more in disease surveillance for their own country, so they don't have to rely on models. And that could also improve the models. So if the modelers have better data to rely on, then we'll be in a better place generally. So if I just then quickly take you through some of the other windows or pages, we have, as you might expect, a page on prevention. So this shows meningococcal vaccination programs around the world. And this is, I think, the only visualization that really does show this anywhere. It's complicated because there are so many different kinds of meningitis vaccine, of meningococcal vaccine. And you can filter again according to region and so on. Then you also have below vaccines, so you can go back and forth between countries that have introduced vaccines and also measures of coverage. So you can see what the coverage is for the two main bugs that are looked at. For Hib, which is so we think of Hib as mainly causing childhood meningitis, but it does cause meningitis across the age spectrum. And pneumococcal obviously is something that you're probably a little bit more aware of. It causes, although the sort of biggest group impacted are sort of children under 2, really. It also has a significant burden of disease in people over 65. This, we also have a little visualization. Sorry, that's not the one I meant to show you. We have a little visualization which shows how there's been such speedy progress. And I think in some ways this is one of, to an extent, this is one of the reasons why it's been really hard to get people to believe that meningitis is still an important thing, because they've seen how well vaccines have worked. But the problem is the vaccines aren't available everywhere. They're not quite as widely implemented as we'd like them to be, and there are kinds of meningitis that we don't have vaccines for. So although this is really showing impressive progress, this rollout of a meningococcal A vaccine across the meningitis belt has almost eliminated Men A, which used to cause epidemics with tens of thousands of deaths every year, so it's made a big difference, but it's only eliminated one kind. So we've kind of pushed down one kind of meningitis, and we've seen other kinds of meningitis pop up. So we're now having epidemics of other kinds of meningitis, which I can show you on the next tab, which is the surveillance tab. So this is a bit of a placeholder. It shows you the different surveillance multi-country surveillance efforts that are out there. So you can select which one you're interested in. You can hover over a country and see which multi-country surveillance effort it's covered by. And you can also see that there are big gaps in the world where there aren't actually multi-country surveillance, but in some cases in the US and Canada, there is actually quite good disease surveillance. And we're hoping that, you know, this is a sort of prototype page, and we'd like to be able to include data from regions of the world, real meningitis data, that will also help to sort of show that comparison between the estimates and the real data. And this is a little visualization we've done showing what's possible. So this just shows, you know, again, it's interesting because it shows it is playing, isn't it, slowly. It shows outbreaks and epidemics appearing across the African meningitis belt. So this is just for one area, for one surveillance effort, but you know, it shows what's possible, and we'd like to be able to show more of this sort of thing. So diagnosis and treatment is also a pillar within the roadmap, and at the moment we have what we think is a pretty clever visualization which shows how mortality is inversely linked to sort of socio-demographic indexes and access to healthcare, but we'd like to be able to include more specific data on diagnosis and treatment for meningitis. The support and aftercare page tells you about how impairment from neonatal meningitis and septicemia varies around the world, and you can see there are different measures here. And we also are wanting to develop this page by linking to sort of video accounts of the personal impact it's had on individuals. And if you click on different areas, you will find that there are different videos available, but it is definitely very much a sort of work in progress. We're not there yet with that. So the tracking progress one is one that we hope to use to be able to really monitor what's going on with the roadmap. You can see that you can rank your, you know, you can see where your country is in the ranking, and depending on the measure you select, you might, it changes. The other thing that you can do is you can use this, so if you are, for example, interested particularly in people, you know, what is happening with people aged over 65, you can select that age range. So, you know, this is just I just had a look at this, and it's interesting because you can see that while cases have plateaued, of meningitis from all causes have plateaued across the years, and deaths are dropping, the pattern isn't the same for people over age 65. And you can come up with perhaps some different ideas about why that might be the case. So it's, I think, you know, there are some interesting patterns that you can draw out. The country profile page is one where you can sort of look at your own, so you can choose your own country and decide, you know, just see what the different patterns are for that country, for example. And again, this is a page very much in development, and it, you know, we've shown some things here about what aspects you might want to be able to track and look at, but this is a placeholder, and we'd like to be able to show more. It also links out to patient groups in the different countries that can offer local support for people affected. And in the fullness of time, we would like to be able to fill it in with lots of different surveillance efforts out there. So at the moment, I've selected Canada, which isn't part of a multi-country surveillance unit, at least effort, at least not as far as we know. But you know, we are hoping that we will be able to fill more in as we go along. So yeah, and then I guess lastly, we have this final screen because we're wanting to evaluate it. We'd really like to know what you think, what things you think you'd like to see, things that you think might be particularly useful, and just sort of general thoughts about it. We'd really welcome feedback. And I think I've probably said enough, possibly too much. So I'll stop talking now and hand back over to Jane and Andra.
Thanks very much, Linda and Rob. So we now have the town hall open for questions. I think one of the questions, perhaps if I can kick it off, and I've lost, I'm here, but where am I? All right, now I'm here. All right, I feel better when I can see my face. So a question to both Rob and Linda is, so what? Why should people in the field of ageing care about meningitis or the meningitis tracker? And I know it's a bit of a provocative question, but I think it's an important one, because if I go to some of our members and say, okay, as part of IFA's vaccination sort of strategy, we really believe that it's important to start talking about meningitis as well as flu and pneumococcal pneumonia and shingles. And they would say, we don't have the bandwidth, I don't know anything about it, and it doesn't impact older people. So what would you say to those people that say, so what, why should we care?
I might start. Rob might have some things to put in, but I suppose one thing is that obviously we think of them as diseases of childhood in particular, and it's true that the incidence of meningitis has historically and still is higher in children under 5 than it is in other age groups, but there is a sort of secondary peak for most meningitis pathogens as you age. And I think another thing to sort of bear in mind is that the case fatality rate ratio from nearly all the meningitis pathogens, certainly the bacterial ones, is higher. So it becomes higher as you get older. So if you do get meningitis and you're over 65, your chances of survival are less than if you get meningitis and you're 1 or 2 years old. So I think that's a reason. The other thing is that we also think that as vaccines are introduced, they do start to, so we have this, what we hope will be sort of a herd effect. It's called population immunity or community immunity or herd immunity or herd protection. It goes by different names, but I think the other thing is that advocating for vaccines, you might sort of think, well, why bother advocating for vaccines when vaccines are mostly introduced to get just for younger children. And I think, there is a rationale for certain vaccines to be offered specifically to older people, but I think that it is still worth advocating for vaccines, whatever your age is, to be introduced for children, because vaccines against many of these forms of meningitis given to the youngsters stop disease in older people. So pneumococcal, I think you probably quite a lot of you know about pneumococcal as a case in point. The main carriers are children under 2. They snot and sneeze and cough all over the place, and older people catch it. And if you, since they're the sort of key carriers, if you vaccinate them, you protect the whole population. For meningococcal disease, if you vaccinate teenagers with a vaccine that can prevent the bug from being carried in their throats, you protect the whole population. So again, these are all reasons, I think, to think more broadly about meningitis across the whole population, because it has an impact on everybody.
Okay, all right, Rob, did you want to add anything to that?
Yeah, I was just going to share a story actually. There's somebody called, I'm just going to share my screen very quickly so you can see somebody that we work with, a guy called Mike Davis. It's just to say really, I mean, when you think of meningitis and we're talking about sort of cases and deaths, but just also the impact it can have on people's lives. So Mike was 60. He's approaching retirement, and he had meningitis, and you can get associated, we talked about associated sepsis with meningitis earlier, but the bacteria can also damage your limbs, your blood vessels, and eventually your limbs. And so Mike's at 60 and suddenly facing a life where he lost both his arms and legs. And we talk a lot on the tracker about the sort of associated disability and impact it can have on people's lives. And so, it's really just to highlight that, meningitis is a disease that can really affect people for the rest of their lives, and the thought of approaching retirement and having to face something like this, I think, is just really quite profound. So it was just to highlight this is a specific story of somebody who has been directly affected and why it's important for to think about meningitis in all ages.
Thanks for that, Rob. If I can just go back, the IFA speaks around the life course approach to vaccination and the critical importance to look at this public health intervention, which is the most effective public health intervention, second only to safe, clean water. But there is critical importance for older people to also have their flu vax, the pneumococcal, shingles, and boosters for many others. So I'll call on Kathy Klein for just a moment. But I think one of the things I want to pull apart in this conversation is, the gateways to vaccination, right? And what I mean by that is, do you go to the GP for the meningococcal? What about because the more gateways that there are available, the easier it is for older people to be vaccinated. So, Kathy, would you like to come forward with your question to Linda and Rob?
Sure, thank you. This is really fascinating. My basic question is, once a child gets vaccinated against meningitis, does that work throughout the life course, or I don't even remember? Do we get boosters? Are we required to have it stay effective? Thank you.
All right, and I'm just going to call on Vijay to come forward. Vijay, can you unmute yourself?
Okay, thank you, Dr. Jane. Yeah, we still have housing units in Mauritius, which were constructed with asbestos. There is a policy of the government to do away with asbestos and replacing the asbestos by other materials in the place of these houses for people, who were victims of cyclones some 60 years ago. My question is there a link between asbestos and meningitis? Is there a link? Is asbestos a cause of meningitis? Yeah, sorry.
Yeah, I know it's a difficult word to get your mouth around, meningitis. So we'll hand it over.
Yeah.
Yeah, Linda and Rob, your comments on both those questions?
I think there's kind of to link them together. I'll hand over to Linda for the sort of science of it, but just to kind of link those two together, like meningitis is caused by kind of a range of different things. So lots of different bacteria can cause meningitis. It's a sort of syndrome. So it's a swelling of the linings around the brain that can be caused by viruses as well. So it's not just one vaccine. We actually have a range of different vaccines that all work in slightly different ways with slightly different lengths of action, if you like, and different booster requirements. And I know that there are some of the things that aren't necessarily bacteria and viruses that cause meningitis, but I don't think I'll let Linda answer the question specifically on asbestos, but I don't think there's any link between asbestos and meningitis that I know of. But I'll let Linda answer that, and perhaps Linda, you could answer about the boosters requirements for some of the vaccines. I know pneumococcal, for example, I think there's a booster there, isn't there, for older age groups. So just I'll pass that over to Linda for the science bit.
Yeah, so with the asbestos question, I think Rob's right. There's no link that I've ever seen between asbestos and meningitis, but it is a good point that we think of the main bacterial causes, but viruses and fungi, different ones, can also cause a meningitis. And there have been associations between some of the types of fungal meningitis that leave spores and various building type issues to do with damp, I think brick dust. I mean, this is relatively niche. I don't think it's a huge, massive cause, but to my knowledge, there isn't really anything that's ever been linked in terms of asbestos. Moving to the first question about lifelong protection or boosters. So none of the sort of subunit vaccines, which all the bacterial meningitis vaccines are, can provide lifelong protection. The MMR vaccine against measles, and measles, you can think of that as kind of a meningitis vaccine because measles and mumps can cause viral meningitis. So those, once you do have pretty much lifelong protection from those live vaccines. But for the subunit bacterial vaccines, the sort of killed vaccines, if you like, they only act for a certain length of time. We thought that perhaps our immune system's memory might mean that if you vaccinated babies, they would still be, you know, that their immune memory would produce antibodies quickly enough if they were, you know, if you came across meningitis later on, that you would still be protected. But that actually, in terms of direct protection, doesn't quite work because meningitis acts so fast. So you actually have to have antibodies in your system to be personally protected, and those antibodies do wane at a certain rate. So at the moment, policies in countries are kind of a mixture of pragmatism and trying to protect people at the age at which it's most important to protect them, and also where you can have the biggest impact on the herd, the population, in terms of protecting the whole population. So that's why for pneumococcal vaccination, you're immunizing babies. So at the time of life, when they're most likely to get it themselves, they're protected. And at the time of life, when they're most likely to transmit it to other vulnerable people in the population and in their families, they're stopped from passing it on. And there is a booster. So I think in many countries, you have sort of a primary schedule in babyhood and then a booster at plus 1 year of age. And then there is a different pneumococcal vaccination that is offered to older people. And to my knowledge, it's a different vaccine in most countries than the one that's used in babies. There may be country level variation in that I'm not aware of. For again, it varies a bit, but for the meningococcal vaccines that can provide a sort of herd protection, so that can wipe out the bugs from the back of the nose and throat, vaccinating teenagers who are a risk group, and in Australia in particular, the kind of concentration of cases in childhood is a bit different in some countries. And Australia is a case in point where they've actually introduced quite a lot of meningococcal vaccines for the teenage age group, because the cases are slightly higher in teenagers, and because they're the ones teenagers and young adults carry. You vaccinate them, it probably only lasts into their 20s, but that's long enough for them to be protected when they're in this kind of vulnerable period, and also to stop them passing it on to other vulnerable people in the population.
So we'll move on to a couple of more questions. Andra and Kathleen Brescia. So Andra, your question?
Thank you so much, Jane, and thank you for the presentation. I'm really intrigued and had a question around chronic conditions, because we see that many underlying conditions often exacerbate the impact of many vaccine preventable diseases. So just wondering if this is also the case with meningitis, and are those specific patient groups and perhaps specialists as well involved in the advocacy and raising awareness, etc.
Okay, and I'll come to Kathleen Brescia, and then we'll come back to you and Linda and Rob. Kathleen?
Thank you, Jane, and thank you for the presentation, which I found fascinating. The data is wonderful, and my question is about how can we help people interpret the data. So data in and of itself, while it's crucial, it's actually the interpretation and the synthesis and how we create a story about that data. And linked to that is the really important intergenerational connection. So how can we work with older people to support vaccination of younger people, which has the double fold back that it protects them as well. So it's about how do we use the data and make and put it to work in a way that helps communicate.
I'll let Rob go first on this one.
I think it's a really a good question. The tracker we have at the moment is in early stages, and we have started. I'm quite pleased that we've managed to kind of think of it from an advocacy perspective, because a lot of the data visualizations you see are just graphs and charts, and we have started to include some stories, real stories on there, so you can access videos and see how meningitis is really affecting people. And then on the country profile page, we're starting to get to a point where some of that data is a little more simplified, so we have some visualizations that are easier for people people to perhaps understand and manipulate them on some of the other pages. But I agree that's very much the starting point. What we do want to get to with the country profiles is something that people can just print off, that really is something they can take to a policymaker, or if they're having a discussion with you know, an influencer or somebody in you know, in their government, that they can really just take the information as a one-stop shop to have everything they need. But it is very much a work in progress. We've actually got some workshops coming up with users or potential users to try and find out what they need and how we can help them with this data. So I think that's something that's going to be developed a lot further. On the using older people to advocate for you know, vaccination younger people, I think it's a really brilliant idea, you know, talking about that protection. It's not, to be honest, it's not something we've done yet, but I think it's a really good suggestion and good idea. And especially moving forward, now we have the global plan. We're working next year with World Health Organization and some other organizations to develop the types of campaigns that are going to really galvanize action. So we're in that process of thinking what campaigns are needed, how are we going to make you know, make people take action. And I think that's a really great suggestion for us to take forward, so that we're not just, you know, focusing on more, you know, the people that are interested in child health, for example. So I can really say thank you for that. I think it's a brilliant idea, and we might steal it.
Okay, and I just want to go back before I call on Eileen from Ireland, and just comment that, Eileen, shingles, the vaccine for shingles is not part of public health vaccination free in some countries, but in other countries it is. And I think when we look at vaccination schedules, you know, they're highly complicated, unfortunately. Canada, case in point, you know, there are different schedules for different provinces. And that goes not only for older people, but for some other population groups. And that's what makes it so difficult. But that should not stop us. You know, we have a responsibility. So Eileen, would you like to come forward with your question? I know you're there.
Yes, sorry, Jane.
That's all right.
I'm having, it's the mouse doesn't respond all the time on my PC. No, what I'm saying is that what targets will be set as regards how recent is the data? Because if it's not up to date, it's not of any use for advocacy. For instance, we have a fantastic global data hub on electoral divisions for our COVID, but the data is only up to the middle of August, and people are supposed to know, you know, if it's in your area. So that's useless. So I'm just wondering how up to date will your data be?
Yeah, I mean, at the moment, we're relying on the models. So the model and the latest models actually only go up to 2017. There will soon be data released going up to 2019. So the models are always retrospective, but we hope, and this will be a sort of triumph, I think, of negotiation, to be able to, as much as possible, to link to national surveillance, which could potentially be real time. So data from the meningitis belt, for example, the little visualization that I showed you, are weekly data, and although we actually don't have the weekly data, the most recent weekly data, because we started making this a few months ago and we just haven't managed to incorporate it. There's, you know, we ought to be able to, and we do plan to be able to keep up to date with the weekly data, which are pretty much in real time. So that, you know, I think it partly depends on what's available. We don't create the data, we rely on the data that are there, and on the willingness of the data holders to share the data. So that's, I guess that partly answers your question. I realize I also didn't answer Andrew's question, so I could just quickly say that risk groups for meningitis are definitely important. A lot of countries have risk group only recommendations for vaccines. So people with immunocompromise, it does vary according to the bug. So for, and you're probably available that there are specific risk groups for pneumococcal, slightly different and fewer for meningococcal and for Hib. And I probably won't go through all of them because there are too many, but things that result in immunodeficiency, things that so sort of cause a hole in your skull so that the bugs can get through either from the environment or from your nose and throat and into the meninges directly. These are all things that are potential risk factors, as well as things like diabetes and asthma and so on are also to an extent risk factors, but most countries don't have policies around them, I think, because it just becomes too huge and too expensive.
I think also, Linda, well, we know, because we do a lot of work in this area, that the definition of risk as defined by the National Immunisation Technical Group changes from country to country. So I'm just going to go to 3 more questions. Dr. Bill Smith, Margaret Teaford, and we'll stop there.
Okay.
Oh, and Mark Venning, sorry. So Bill, over to you.
Very good. First of all, a very interesting presentation. Thank you. My recollection is that when we see young people going into college residential settings, there's always a split or a spurt of more meningitis, and they try to look at the vaccinations at that time, perhaps even boosters. But my question really goes around, how do we raise the awareness to get member states or countries to really take this disease seriously? You know, is there something that could be done to do that? How do you get a groundswell? The data is important, but what's preventing countries to present that data to you for analysis? Thank you.
Margaret Teaford, and then Mark Venning. Margaret?
Good morning. I just wondered, building on Bill's question, what kind of, excuse me, what kind of barriers are there? Is there resistance, particularly to these vaccines? And what more could be done to really, as Bill suggested, heighten awareness?
Okay, thank you. And Mark Venning?
Yeah, mine isn't really a question, it's more of a comment. I find this session to be highly educational, so thank you very much once again, IFA. It's also very timely in my mind because we can learn a lot from this tracking device, how we handle COVID tracking and education going forward. So maybe we could add this to the list of things IFA tracks.
Oh, look, I think this is one of the reasons that we had MRF with us, because going forward, we're going to have a number of different sessions on this. So, you know, you're absolutely correct. So Linda and Rob, back to Bill's question and Margaret's.
Yeah, I think I was reading through Bill's question before, and he mentioned the kind of economic element. With raising awareness, it's kind of double-edged sword. We're actually quite lucky with meningitis in that it's a disease that people really fear. So where it happens, we know that people know about it and they're scared of it. That's partly because it acts so quickly. Somebody can go from being healthy one day to, you know, can kill somebody within 24 hours. So, you know, we know that it does resonate with people, and we're fortunate that when we do those campaigns, it does work. It's just trying to drive governments to carry out those campaigns. I'm a real believer that once we get them, people will listen, because they tend to listen to our campaigns in the UK, which is good. And you mentioned economics, and that's a hugely important part of it. So in the UK, when we've tried to get vaccines introduced, we've often been faced with challenges from government saying it's too expensive, there aren't enough cases, you know, to vaccinate people. And so we've played a really big role, Linda's team, in gathering evidence to show that economic argument and to say, you know, here's the data about cases, but you know, it's not just the deaths we're looking at, we're also looking at the economic burden of disease for those that survive. So, you know, meningitis can lead to brain injury and deafness, and as we explained before, when sepsis occurs with it, it's, you know, can lead to amputation. So there can be a huge cost, and we actually did a big piece of work to work out how much a severe case of meningitis can cost the government, and that was really instrumental in getting some vaccines introduced in the UK. And we've started to see other countries do that now as well. So France, I think, has done an economic evaluation, and Burkina Faso in Africa. And those kinds of initiatives, I think, really help. And that is something, I think, the tracker, eventually, you know, we can help to put those sorts of tools on there as well and tell those stories. One of the plans we have next year is to roll that initiative out as a toolkit to encourage other people to do that economic evaluation where they can, to help convince their governments. And just on the question about, you know, barriers to vaccine. So there's the barriers of introduction, but then, you know, once the the vaccines are there. And Margaret was asking, why, what are the barriers for people accessing it? So I'm just going to very quickly show a kind of model that we use when we're talking about that, which is called the 3 Cs, which shows kind of the difficulties for people getting vaccines. And that's really complacency there at the top is really vaccines are too successful for their own good. Vaccines get rid of diseases and then people don't see them anymore. We've seen that with measles, for example. People, stop worrying and think, well, maybe I don't need that vaccine anymore. The confidence at the bottom left is where we see some of the issues with vaccine hesitancy and people worrying about vaccine safety. One of the kind of key things I think there when we talk to people about that is that with vaccines, you're giving a medicine, essentially a drug to somebody who's healthy, and we normally give medicines to people when they're ill. So if you're ill in bed and you feel horrible, you're probably more willing to take something than if you're perfectly healthy and somebody's asking to put a syringe in your arm. So we have to do a lot to make sure people are confident that when they're getting this vaccine, it's going to be safe. And that's really where those kind of confidence issues arise. And then obviously we do have issues around anti-vax sentiment, which often comes from misinformation, which can come from a variety of sources. So that's one of the other issues. And one of the biggest issues we face in the UK, so we're very lucky in the UK in that we don't really have much of the complacency and confidence issues, but mostly around convenience and access. So making sure people can actually get the vaccine. So it might seem easy to go to a doctor and ask for your child to be vaccinated or as an older person to get vaccinated. But if you're in need of care at home and you can't get to that doctor's appointment, or if you've got children and you're struggling to manage the lives of 3 children and take them all to appointments, that access can be kind of a real issue. So that's just wanted to share that with you as the kind of main barriers we see.
Thanks very much for that, Rob. As we move to close on the hour, I'm going to ask Rob and Linda to provide, what are your key takeaway messages for the audience today? And I just want to follow up also, Rob, about the question about barriers. Cost is a big barrier for older people, right? In most countries, the cost of pneumococcal vaccination is very high. And it's not available. I think also for older people, mobility, how do I get to the doctor, right? I think also that some of the systems to be vaccinated, I know in some parts of Italy, you've got to go to the doctor, get the prescription, go to the pharmacy, get the vaccine, then go back to the doctor to actually be vaccinated. So you just go, I think the other aspect that you mentioned was I'm healthy, I don't need it, right? So the level of awareness around the value of for my health and well-being, is actually quite low in many countries. And I think what we tend to do is the messaging is very poor. So we've just, IFA has just completed a 10-country study to examine public health messages around influenza campaigns. And while there's some good examples, there are some major gaps, because at the end of the line, it's equity. And, many and most times in COVID, and also in flu season and with pneumococcal and with shingles, the poorest of the poor will pay the highest price. And so, some older people that are hospitalized with influenza, will actually have inflammaging, 2 and 3 years down track, and will never return to their pre-hospitalization function. So this is a very big conversation that we need to be having across the coming months and years, because it was here before COVID. And now, as Mark Venning was saying, what are the lessons that we can be learning as we go forward? So I'll hand it back to you, Linda and Rob, for some closing messages before we share the excitement of next week's town hall. So who would like to start?
I'll go first just because that'll make it easier for me. I'll pinch the easy one. But I guess I think that one of the things that really comes across when you look at the tracker, but also from the work we've done with WHO on on the initial sort of burden of disease document that underpinned the roadmap, is that it is something that affects all people in every country of every age, and it's the way the diseases behave. Things are interconnected. So you know, just to kind of magnify what Jane said earlier about how you know, what happens in children can affect what happens in older people, and vice versa to an extent. So I think it's important. I'm also really hoping that what we're doing now will keep bringing home the message that we haven't, you know, meningitis isn't a job done. I think people think, oh, there's pneumonia and there's sepsis, and they kind of forget that meningitis isn't a thing that just had a vaccine that worked and we can just dismiss it now. We might have really good vaccines in some high income countries and a brilliant campaign that happened in the meningitis belt, but there's still lots of types of meningitis we need to continue to combat. So I'll stop there.
Okay, Rob.
Yeah, I think, you know, coming back to what you said about Italy there, and, you know, it's the same in France in terms of how people access vaccines. I think it's a good reason to remember that it's not a kind of one size fits all solution with meningitis either. And, you know, the meningitis does affect, you know, lots of people in lots of countries, but it can be very different in those countries as well about how it affects them. So, you know, for example, in the meningitis belt in Africa, a strip across the north of Africa, there's you know, lots of epidemics that we're looking at. In other countries, it's sort of smaller individual cases and different causes of meningitis. So the tracker for me does a really good job on two levels in providing that global picture, so we can talk about meningitis on a global stage, but also providing those breakdowns so that people can use something on the ground in their own area and really get the information they need to talk to their own policymakers. And we hope to improve that so that people can really see what the issues are and the barriers are in their country that need to be addressed. And that's really a piece of work from next year that we're hoping to help people out a bit more, so that when you're talking on a regional or national level, you'll have the information that you need that's going to make a difference.
Look, thanks, Rob, and thanks, Linda, and you can count on the support and encouragement of IFA. You know, why should we be care? Why should we care about this? Because it's the right thing to do. You know, we know older people, middle-aged people, children, we're all at risk of meningitis. So we need to stand together with a single voice, because when we have a single voice and a single message, then it's much easier to convince the policymakers and the funders, as well as families who really should be addressing this, you know, across the life course. So we thank both of you today. It's a new area for us, and it's one that needs to be on our agenda.